Good afternoon, students. The topic of our lecture is myocarditis and pericarditis. Myocarditis definition. Myocarditis, also known as inflammatory cardiomyopathy, is inflammation of the heart muscle. The main causes of myocarditis. Myocarditis is an uncommon disorder that is usually caused by viral, bacterial or fungal infections that reach the heart. Viral infections, Coxsackie, cytomegalovirus, hepatitis C, herpes, HIV infection, and parvovirus. Bacterial infections, chlamydia, mycoplasma, streptococcus, treponema, fungal infections, such as Aspergillus, Candida, Cryptococcus, allergic reactions to certain medications or toxins also is the cause of myocarditis, such as toxins such as alcohol, cocaine, certain chemotherapy drugs, heavy metals. Being around certain chemicals, certain diseases that cause inflammation through the body, rheumatoid arthritis. Symptoms of myocarditis. There may be no symptoms. Symptoms may be similar to the flu. If symptoms occur, they may include abnormal heartbeat, chest pain that may resemble a heart attack, fatigue, fever and other signs of infection including headache, muscle aches, sore throat, diarrhea, or rashes. Joint pain or swelling, leg swelling, shortness of breath, other symptoms that may occur with this disease. Fainting, often related to irregular heart rhythm, low urine output. Exams and tests. A physical examination may show no abnormalities or may reveal the following: abnormal heartbeat or heart sounds, such as murmurs, extra heart sounds. Also fever, fluid in the lungs, rapid heartbeat, so-called tachycardia, swelling, edema in the legs. Tests used to diagnose myocarditis include blood cultures for infection, blood tests for antibodies against the heart muscle and the body itself. Also chest X-ray, electrocardiogram, heart muscle biopsy, so-called endomyocardial biopsy, red blood cell count, ultrasound of the heart, echocardiogram, white blood cell count. On this picture, you can see pathophysiology of myocarditis. And we can comment, we can see that cause of viral myocarditis is characterized by three main phases. It is acute phase, virus replication, from the first day after viral infection to the 10th day. From the 10th day, it is the beginning of the subacute phase, so-called immune response. And from 30 days to 90 days, it is chronic phase, the development of dilated cardiomyopathy. And to conclude, there are three main phases of the myocarditis development. It is virus replication, acute phase, it is immune response, subacute phase, and it is chronic phase, dilated cardiomyopathy. Electrocardiogram. The ECG findings in patients with myocarditis vary from non-specific T-wave and ST segment changes to ST segment elevation mimicking an acute myocardial infarction. Also atrial or ventricular conduction delays as well as supraventricular and ventricular arrhythmias can occur in patients with inflammatory heart disease. The presence of Q waves or a new left bundle branch block are associated with high rates of cardiac death or heart transplantation. So on this picture you can see the picture of the patient with myocarditis, which looks like acute myocardial infarction. The changes are in the first AVL, V2, V3, V4, V5 and V6, and also second, third and AVF leads. Also the picture of the patient with an acute myocarditis. The same. Electrocardiogram. On this picture you can see classical appearance ECG myocarditis simulating a myocardial infarction. Echocardiography. There are no specific echocardiographic features of myocarditis. However, echocardiography allows the evaluation of cardiac chamber size and wall thickness, as well as systolic and diastolic function in the patients with myocarditis. Patients with fulminant myocarditis often have normal cardiac chamber sizes with an increased septal thickness secondary to acute myocardial edema, whereas patients with acute myocarditis have marked left ventricular dilation and normal wall thickness. Cardiovascular magnetic resonance. Cardiovascular magnetic resonance (CMR) imaging has evolved as a non-invasive and valuable clinical tool for the diagnosis of myocarditis. Endomyocardial biopsy. The gold standard is diagnosis of myocarditis is still the endomyocardial biopsy. And according to the Dallas criteria, acute myocarditis is defined by lymphocytic infiltrates in association with myocyte necrosis. Borderline myocarditis is characterized by inflammatory infiltrates without evidence of myocyte necrosis. The Dallas criteria are limited by the high inter-observer variability in interpreting biopsy specimens, in particular with regard to borderline myocarditis, and because non-cellular inflammatory process cannot be detected. Dallas criteria introduced in 1986 for pericarditis, and we can use it also, as I told previously, for the diagnostic of myocarditis. And these criteria are based on endomyocardial biopsy specimens. Active myocarditis if light microscopy revealed infiltrating lymphocytes and myocytolysis. Borderline myocarditis or ongoing myocarditis if lymphocyte infiltration and no myocytolysis. And negative for myocarditis if no lymphocytic infiltrate and no myocytolysis. Treatment. Treatment of myocarditis is aimed at the cause of the problem and may involve antibiotics, anti-inflammatory medicines to reduce swelling, diuretics to remove excess water from the body, low-salt diet, and reduced activity. Specific treatments, specific types of myocarditis based on autoimmunity are treated with immunosuppressions, for example, in patients with giant cell myocarditis or cardiac sarcoidosis. In case of giant cell myocarditis, combined treatment with immunosuppressants such as cyclosporine and corticosteroids with or without azathioprine may improve the poor prognosis and yield a median survival time of 12 months compared with 3 months for untreated affected patients. Nevertheless, a minority of patients require mechanical circulatory support or heart transplantation within 1 year. Physical activity in acute myocarditis, avoidance of aerobic physical activity is indicated in addition to pharmacological therapy. In patients with stable heart failure after previous history of myocarditis, physical exercises are recommended. Prognosis. Patients with acute myocarditis are preserved left ventricular ejection fraction, have a good prognosis with a high rate of spontaneous improvement without sequelae. In patients with cardiac sarcoidosis or giant cell myocarditis, prognosis depends probably on an early initiated treatment, immunosuppressive therapy, or heart transplantation. Treatment for myocarditis may include corticosteroid therapy to help reduce inflammation, cardiac medications such as beta blockers, CETP inhibitors, behavioral changes such as rest, fluid restriction, and a low-salt diet, diuretic therapy to treat fluid overload, and antibiotic therapy according to the indications. Complications. Possible complications include the sudden loss of consciousness, such as syncope, abnormality fast, slow, or irregular heartbeat, cardiac arrhythmias. Also, complications can be cardiomyopathy, heart failure symptoms, and pericarditis. Pericarditis. According to the definition, pericarditis is inflammation of pericardial layer of the heart. Pericardial layer covers the heart and protects it from any infection. The main causes of pericarditis: idiopathic, viruses, bacteria, tuberculosis, HIV, metabolic illnesses, kidney failure, uremia, and hypothyroidism. Symptoms. The main symptoms of pericarditis can be chest pain. Patients feel rough than lying flat. Other symptoms may include fevers and chill sweats, shortness of breath, difficulty swallowing. Clinical findings depends on the type of inflammation, severity of inflammation, and formation of pericardial fluid. It can be, according to the clinical findings, the types can be dry pericarditis, pericardial effusion without cardiac tamponade, or pericardial constriction. A dry pericarditis or fibrous pericarditis. Symptoms: chest pain. It is pericardial, radiate to shoulders, so mimic the acute myocardial infarction pain. But the pain of pericarditis increase intensity with inspiration or lying flat and improve when standing or sit down or leaning forward. Fever, arthralgia, rigors, anxiety, and general weakness. A pericardial effusion without tamponade. The symptoms in this case are disappearance of chest pain, ECG changes, flat T wave, low voltage ECG, complications of pericardial infusion, cardiac tamponade, and fibrosis, minimal effusion, and this called seroconstrictive or subacute inflammation. Diagnostic, history and physical examinations. It's necessary to know diagnostic testing, ECG or echocardiography. ECG may be normal. Chest X-ray is usually normal. However, if fluid accumulates in the pericardial sac, the heart can appear larger on the X-ray, and also it's necessary to have echocardiographic signs of echocardiographic results, as I told previously. Characteristic of ECG changes: widespread concave ST elevation and PR depression throughout most of the lymph leads, first lead, second, third, AVL and AVF, and precardial leads from V2 to V6 leads. Reciprocal ST depression and PR elevation in the lead AVL, plus minus in the lead V1. Sinus tachycardia is also common in acute pericarditis due to pain and or pericardial effusion. Stages diagnostic, also ECG diagnostic and stages of pericarditis according to the ECG changes. Pericarditis is classically associated with ECG changes that involve through 4 stages. Stage 1, widespread ST elevation and PR depression with reciprocal changes in ADR occurs during the first 2 weeks of pericarditis. Stage 2, normalization of ST changes. Generalized T-wave fluttering from the first to third weeks. Stage 3, flattened T-waves become inverted from third to week to several weeks. And stage 4, ACG returns to normal during several weeks onward. Acute pericarditis. Here on this ACG you can see acute pericarditis, and the signs are widespread concave ST elevation and PR depression is present throughout the precordial from V2 to V6 and limb leads, first lead, second lead, AVL and AVF leads. And there is reciprocal ST depression and PR elevation in the lead AVR. On this electrocardiogram, you can see also the signs of acute pericarditis. It is sinus tachycardia. It is widespread concave ST elevation and PR depression in the leads, first, second, third, AVF, and leads from V4 to V6, and reciprocal ST depression and PR elevation in the lead V1 and in the lead AVR. And also spodic stein, best visualized in the lead 2. Spodic stein. It means downsloping TP segment seen as an early ACG manifestation in 80% of patients with pericarditis, best visualized in leads second and in the lateral precordial leads. So the best vision of spodic sign in the second lead of electrocardiogram. Treatment of pericarditis. Several indicators of poor prognosis of pericarditis. If the fever is more than 38 degrees by Celsius, fever is more than 38 degrees by Celsius on the first place, then subacute onset, immunosuppressed, after trauma, anticoagulation use, myopericarditis, and large effusion or tamponade. All of them are indicators of poor prognosis. The treatment is aimed at decreasing inflammation and controlling pain. Non-steroidal anti-inflammatory drugs we can use, such as ibuprofen and naproxen. As the methods of treatment according to the indications, we can use pericardiocentesis, pericardiotomy, pericardioectomy. And thank you for your attention.